dizziness, which obviously is a really big topic, so it's difficult to cover everything, but I've selected some of the ENT stuff that's very important, and I've gone through some of the peripheral causes of vertigo, some of the important central causes of vertigo, and also when you're taking a history, what are the key points to ask, and also how to do an examination and what investigations are really important. So as we know, dizziness is a non-specific symptom, and whenever we get a referral about it, we have that heart sink moment. And I find that patients often really do have difficulty describing what they're feeling as well. It's really difficult to ask open-ended questions because they end up saying yes to everything. So vertigo is different to dizziness, and it's a specific sensation of rotatory movements, and it's not the same as lightheadedness or unsteadiness, which often get referred to us as well. So like I said, the differential diagnosis is really broad, but the question is it peripheral, which mostly are very benign causes, or is it central, which could potentially be a lot more dangerous? And I think with vertigo, a careful history is the most important thing that you can do as a clinician, and pay really careful attention to triggers and timing. So I thought I'd go through some of the peripheral causes of vertigo first. And I'll mainly concentrate on BPPV, Meniere's, and labyrinthitis or vestibular neuronitis. But I'll also talk about a few more different things that I think you might find interesting or useful to know. So peripheral causes of vertigo, so these are pathologies that arise from the semicircular canals. So the semicircular canals usually help us orientate ourselves in time and space and let us know about angular movements. The utricle and the saccule, which are connected to them, and they let us know about horizontal and vertical movements, and also the vestibular nerve, which relays that information to the brain. So I've said BPPV, Meniere's, labyrinthitis, vestibular neuronitis are some of the main ENT causes, but I will also go through very briefly about other things like temporal bone fracture, perilymph fistula, etc. So BPPV happens, usually it affects the posterior semicircular canal, and it's usually when loose otoconia from the utricle become dislodged and enter the semicircular canal. It's commoner in the middle to elderly age group, so usually between 50 to 70, and usually it's idiopathic, but head trauma is a possibility, especially if the patient's a bit younger than the age of 50 to 70. So it's provoked by head movement, and it lasts only seconds, and that's really, really important. So it happens 2 or 3 seconds and then it's gone, and you classically have this provoking head movement to one side that brings it on, and it's usually when they turn over in bed. So the first episode is usually the worst. What I want to stress again is, so there's usually no nausea or vomiting with BPPV, and the patient doesn't really tend to have any ear symptoms. It's isolated vertigo lasting a few seconds provoked by head movements. So the diagnosis of BPPV is confirmed by the Dix-Hallpike test. So if we go through the pictures, so A is showing the patient lying on the patient couch. And I think the Dix-Hallpike test is actually really easy. It scares a lot of people, but I think anyone can learn how to do it. So you basically hold their head and lay their head down over the couch. The patient should be a little bit further up than this, really. And you get them to keep their eyes open, and you're looking for development of nystagmus. So then classically, if it's posterior semicircular canal BPPV, you get latency, fatigability, reversal on sitting, and geotropic direction, which means that it's downbeating. And you treat this with what's called the Epley maneuver, and it's like magic for patients. So if we look at A and B, so that's the initial Dix-Hallpike test. So you do the same thing again, and then you turn their head by increments of 90 degrees until they get sat up again. And you might have to do this several times in order for it to be fully effective. But like I said, usually the first episode is worst, and it gets better with the Epley maneuver. And you can discharge these patients very safely with Branderoff exercises, which are kind of canalolith repositioning exercises that you can do on your own at home, or you can, if they're living with somebody else or they have a partner, the partner can be taught the Epley maneuver to do whenever this happens again. Then I wanted to talk about Meniere's disease, which is also called endolymphatic hydrops. And if we remember back to our anatomy of the labyrinth, we know we have the scala media and the scala tympani and scala vestibuli. And in the middle, you've got your endolymph. So with Meniere's disease, for causes unknown, you get overproduction of endolymph, which causes progressive damage to your vestibular apparatus as well as your cochlea. And the damage to the cochlea is really important in coming to this particular diagnosis. So with Meniere's disease, they get vertigo only of several hours duration. So it's considerably longer than what would be for BPPV, but nowhere near as long as it would be for something like labyrinthitis or vestibular neuronitis. Usually the patients don't feel very good with it, so you get profound nausea, vomiting, they want to lie down in a dark room. And they also have these otological symptoms such as unilateral hearing loss, oral fullness, and importantly, tinnitus. And because of the endolymphatic hydrops, it damages the hair cells of the cochlea. So these patients get hearing loss that fluctuates over time. And with progression, they get low frequency sensory neural hearing loss, which is a really key diagnostic point. So your diagnosis is really from a typical history and then an audiogram showing low frequency sensory neural hearing loss that's progressive. So Meniere's disease, it gets better after a few hours, but you can trial them on beta histine 16 milligrams TDS in order to reduce the frequency and severity of attacks. But also there's a strong link with stress and lifestyle factors, so limiting fluid, limiting caffeine and salt intake, trying to get them to reduce their stress levels, diuretic therapy to reduce the fluid pressure inside the cochlea, can be measures that can be instigated. More specialist measures that could be done in ENT are intratympanic steroids or gentamicin. Some people do grommets for these things, very limited evidence though. End-stage Meniere's disease, you might want to think about doing a labyrinthectomy even, and we would supplement their hearing with a hearing aid. So I think a large proportion of our referrals are because of vestibular neuronitis or labyrinthitis, and I don't think that the distinction between the two is particularly important. So it's called vestibular neuronitis if we think it's isolated to the vestibular nerve, but if you also have some hearing loss with it, we call it labyrinthitis. But really, both of them are caused by viral infections mostly, and the vertigo is really, really severe, and it lasts much longer than what would be expected for something like BPPV or Meniere's disease. So usually days to weeks, and it's often accompanied by nausea and vomiting. So this is different to Meniere's disease in that you don't tend to have the oral fullness, you don't tend to have the tinnitus alongside it, but if you have labyrinthitis, then you might have some hearing loss. So treatment is usually supportive. We'd recommend vestibular sedatives such as prochlorperazine, for example. Maximum of only 3 days though. So these patients should not really be discharged with vestibular sedatives for a longer period of time. And the reason for that is you want to allow the brain to compensate for this problem, and you won't let the brain do that if you give them vestibular sedatives. So physiotherapy, exercises, vestibular rehabilitation, different consultants have different practices, but Cawthorne-Cooksey exercises, for example, are really effective in helping you to relearn and encourage central compensation. So I've also put this slide in because I know that obviously you guys are from a medical background, and in some hospitals you end up admitting patients with head injuries and things. And temporal bone fractures can also be a cause of vertigo. So temporal bone fractures can be classified into either longitudinal or transverse. You can see a picture of the longitudinal one up there. And these patients can have vertigo, especially if it's longitudinal. You can get vertigo from something called labyrinthine concussion. So if it's a longitudinal fracture, it improves over time. So these patients can just be managed with a bit of rehabilitation and reassurance that it will get better. Perhaps with some vestibular sedatives in the short run would be helpful for them. But patients who have transverse fractures of the temporal bone that actually go through the labyrinth itself, they tend to have really, really severe vertigo and profound sensorineural hearing loss as well that will not recover. So these patients need a lot of rehabilitation, a lot of exercises, vestibular rehab, perhaps with like a very specialist physio team, in order to allow them to have that central compensation again. And I think when we approach dizzy patients, a lot of people don't consider whether they've had a head injury or not, particularly if, say, the patient has dementia or some kind of cognitive impairment. It's really important for us to figure out, have they actually had a head injury that could be causing vertigo. This one is a bit niche, but I thought I'd include it because it's fairly interesting. So another ENT cause of vertigo is something called perilymph fistula. It's fairly rare, but this is when you have perilymph that's leaking at the oval or round window. And again, it can happen after head trauma or temporal bone fracture or even barotrauma. We tend to see these patients mostly after surgical complications such as post-stapedectomy. But these patients, very similar to Meniere's disease, it causes oral fullness, fluctuating hearing loss, tinnitus, vertigo, nausea, and vomiting. So you need to take a very careful history to figure out what's going on. But because they have these good going otological symptoms, it should be fairly obvious that this is an ENT problem rather than a medical one. And then superior semicircular canal dehiscence, a recently recognized cause of vertigo. So if you have a look at the picture, that's a superior semicircular canal at the top there, and it's a defect basically in the bony area. And again, it can be traumatic, although it can be congenital. And these patients are interesting, and they present with vertigo that gets worse when they hear loud sounds. And sometimes these patients get mislabeled as, oh, maybe it's a psychological problem or something like that when somebody says, oh, you know, loud sounds cause vertigo. And they also get bone conduction hyperacusis, which means that they can hear sounds that are bone conducted, they can hear really, really loud in that affected ear. So they can hear their eyeballs moving, or they can hear bodily functions, or when they're walking, they can hear it in that affected ear. And they also get some tinnitus as well. So again, these kind of patients coming in with this type of presentation of vertigo, just have a think about whether they're for ENT. Other peripheral causes that I think are important are a complicated acute otitis media. So patients who've had acute otitis media and the bacterial toxins spill over into the labyrinth, that can cause vertigo. But obviously they would have a strong history of having had an ear infection, perhaps ear pain or discharge, perhaps things like mastoiditis, which would obviously point towards this is an ear problem rather than a central or medical problem. Herpes zoster oticus can also affect the vestibulocochlear nerve, and that can also cause vertigo. So you need to have a good look at the ear and figure out whether they have vesicles or a history of chickenpox. And then cholesteatoma, which is a benign growth of keratin. It can also invade into the labyrinth and cause perilymph fistula and cause vertigo as well. But obviously they would have a very long history of a discharging ear, and if the cholesteatoma is so advanced, they will probably have other symptoms like a facial nerve palsy to go alongside it. I also want to talk a little bit about cerebellopontine angle tumors, because people, I think it's quite a misnomer that it's a common cause of vertigo. It's by no means common, and most cerebellopontine angle tumors, so acoustic neuromas, they actually grow very, very slowly. And because of that reason, you tend to compensate centrally quite well. And these patients more often present with hearing loss or tinnitus rather than vertigo per se, unless obviously the tumor is very large or growing very quickly. And then finally, autoimmune inner ear diseases. So your body can attack your inner ear with autoantibodies, which can also cause hearing loss and vertigo. Does anybody have any questions about those? If not, I'll move on. to central causes. So central causes of vertigo affect the vestibular nuclei, the cerebellum, brainstem, spinal cord, or vestibular cortex. And these are the ones that are dangerous. So I've gone into details about vestibular migraine and cerebellar stroke, but I'll also touch on things like multiple sclerosis. So vestibular migraine is a subset of migraine. So it's episodic vertigo in a patient with a history of migraine. It's important to know that headache doesn't always need to be present, but the patient does need to have a history of migraine, symptoms of migraine during the vertigo attack, and you've excluded other causes of vertigo. So you need to ask the patient whether they have any photophobia or phonophobia. Do they have any migraine triggers? Do they have any auras or seeing any like fortification spectra, for example? We usually end up referring these patients to neurology, so you might be able to tell me more than what I know about this. But as far as I know, it's unclear if migraine abortive therapy like the triptans are helpful in treating the vertigo. And there's also very limited evidence for migraine prophylaxis, such as propranolol. So this is the one that we all worry about, cerebellar stroke. And so if the region supplied by the posterior inferior cerebellar artery is infarcted, the patient may actually present with isolated vertigo. And if a careful history isn't taken, this patient may mistakenly come under ENT. And I just wanted to stress the fact that if you have the anterior inferior cerebellar artery affected, the patient may also have hearing loss, because if you have a look on the picture on the right, the anterior inferior cerebellar artery actually gives off the labyrinthine artery, which supplies our cochlea and labyrinth. So if you infarct this, then the patient may actually have some hearing loss as well. So you might mistakenly think, oh, it's definitely for ENT. The patient has some otological symptoms, but you might be mistaken. So in these, cerebellar examination is really, really important, bearing in mind if the infarct is quite small, you may not have good going cerebellar signs. And I'll go through the HINTS examination in just a minute. And it's really important for us to know as well that MRI misses about 20% of cases of cerebellar stroke, and that CT is not very sensitive for this. So just because your imaging might be negative doesn't rule this out. Multiple sclerosis, so vertigo, is a really common symptom of MS due to demyelination of the cerebellum and brainstem. So again, it's really important to take a good history to see whether these patients may have other symptoms of multiple sclerosis. So this is my usual approach to taking a history from a vertigo patient. So the first thing to really ask them is, can you explain to me exactly what you feel when you say you're dizzy, and is the room spinning? Because then that separates vertigo from other causes of dizziness straight away. I also ask them red flag questions like, do you lose consciousness, or are you aware of everything that's going on? Because that might suggest like a TIA or a stroke. And I also ask about chest pain or palpitations, because it might be a possible cardiac cause. And because patients are not so good at telling us about, oh, we're feeling dizzy, oh, the room is spinning, it's very, very difficult for us to figure out, is it these serious things? I would also ask about weakness in arms, legs, face, or speech difficulty, which again would point to something neurological. And then really commonly missed problem is postural hypotension. So does it come on when you stand up from a sitting position? And all of these questions are very important. It's a bit of a busy slide, I do apologize. And then I've gone into, if it's true vertigo, so the room is definitely spinning, then you need to ask these following specific questions. So how long exactly do the episodes last? If it's seconds, might be a BPPV, hours, points towards the Meniere's, and days, might be a vestibular neuronitis and labyrinthitis. And what are your triggers? So does anything cause it to come on? So if they say head movements, it might be BPPV, but be careful, because you can get vertebrobasilar insufficiency, which can also cause vertigo on head movements. And you can ask, does it come on with loud noise, which is called Tullio's phenomenon, which could point towards a semicircular canal dehiscence or perilymph fistula. Then ask about otological symptoms. So do you have hearing loss, fullness in the ear at the time, which could point towards Meniere's, or tinnitus or buzzing sounds, which could again point towards a Meniere's, acoustic neuroma, or semicircular canal dehiscence. Ask about ear pain or discharge, which could point towards an acute otitis media or a cholesteatoma picture, and then ask about symptoms of migraine, such as aura, photophobia, headache, migraine history. I would always inquire as to tremor, visual problems, any bowel or bladder dysfunction, because MS is easy to miss. And then finally, you need to ask about nausea or vomiting, because having nausea and vomiting strongly points towards a peripheral or benign cause rather than a central one. And within the past medical history, ask whether they've had a head injury, because head injury can lead to BPPV, can lead to perilimb fistula, can lead to temporal bone fracture, all of which can cause vertigo. Ask about any previous ear problems or any previous ear surgery, particularly if it's been recently. Ask about heart problems or stroke and establish vascular risk factors, and then know whether the patient is a diabetic, because every now and again we get a hypoglycemia that's been referred as a vertigo. Within the drug history, you need to know the patient's regular medications, and there's a very long list of things that can cause ototoxicity. And then family history, so Meniere's disease, migraine tends to run in families. Within the social history, know about smoking, because again, that's a vascular risk factor, and know about the patient, whether they're driving or not, because if this is true vertigo or dizziness, the patient will need to be given some driving advice. Within the examination, as a minimum, I'd expect that you check for cranial nerve deficit. So palsy of cranial nerve 5 or 7 might indicate cerebellopontine angle tumor, or any other cranial nerve palsy might indicate a posterior circulation stroke. Do a thorough cerebellar examination again to figure out whether this could be a cerebellar stroke. Within the cardiovascular system, pulse and blood pressure, I should have written lying and standing there as well. And do the Romberg's test, because you might want to check for proprioceptive loss. Ears, so check for any vesicles that could be suggestive of zoster oticus. Check for any cholesteatoma or acute otitis media. The last two, well, actually, this ear examination might be better done under ENT, who see more ears. And then I've also talked about the Unterberger test and the Henenbert's test, which you may not have heard of. So the Unterberger test is quite similar to Romberg's. You ask them to stand up and close their eyes and step on this, so step on the spot. And if one labyrinth is dysfunctional, the patient rotates over to that side. So that points strongly towards a peripheral cause rather than central. And then Henenbert's test is you press on the tragus, and this can cause nystagmus if you have a semicircular canal dehiscence or perilimb fistula, because that gush of air causes that perilymph to move. But those two tests would usually be undertaken by us. And the main thing I really wanted to get across in this talk is the importance of the HINTS examination, which is not done often enough, in my opinion. So it stands for head impulse, nystagmus, and test of skew. And this is really good for patients if they say, oh, they have vertigo, it's still ongoing, it hasn't resolved itself. So what you have to do for the head impulse part is you hold, you ask them to look at you and focus on one area, usually your nose, and you have your hands on either side of their head, and you tell them, keep looking at my nose. I'm going to move your head quite suddenly, but make sure that your eyes are fixated on my nose. And you basically move it really fast to the right, back into the midline, and really fast to the left. And what happens is, if you have a peripheral cause of vertigo, where your ear is affected and your labyrinth is affected, you lose your vestibulo-ocular reflex. So you find that if they have a peripheral cause of vertigo and you move their head to one side, they actually can't keep their eyes focused on your nose. And they look away, and then they have to correct it with a saccade back again. So having a positive head impulse means that it's probably a peripheral one. Whereas if you have a central pathology, your vestibulo-ocular reflex is not going to be affected. So if you have a central pathology, you find that these patients can still remain focused on your nose despite moving your head. So positive head impulse is a good thing. And then you look at nystagmus. So have a look at their eye movements. If you have a peripheral cause of vertigo, nystagmus is almost always horizontal. But if you have a vertical or a rotational element, that's really suggestive of a central cause of vertigo. And then finally, you do the test of skew, where you cover one eye and ask them to keep looking at you. And when you uncover it, if there's a vertical corrective movement of that eye, that probably means that they have a central pathology rather than a peripheral one. So in summary, if you do a HINTS examination, a reassuring one will be unilateral horizontal nystagmus, no vertical skew, and an abnormal head impulse test. And actually, this HINTS examination is found to be more sensitive than even MRI in detecting central pathology. Other investigations you should do, obviously, a BM, an ECG, and a lying and standing blood pressure. We get a lot of referrals where an ECG hasn't been done or a lying and standing blood pressure hasn't been done. And those are really important. More specialist investigations, if you feel like it's an ENT problem, is an audiogram, especially if the patient has some hearing loss or tinnitus. And if you're not convinced that this is a peripheral cause of vertigo, then an MRI is sensitive for brainstem infarcts, cerebellar infarcts, demyelination, and acoustic neuroma. So in summary, what I wanted to stress is that careful history taking, focus on timing and triggers alongside a careful physical examination is key. So vertigo, really, you've got to spend time with the patient, take a really clear history, do a full neurootological examination, and don't rely on the MRIs or the CTs to help you come to your diagnosis, because especially, like I said, MRI doesn't always pick up cerebellar strokes. Rule out cardiac and neurological causes because they're important. Remember HINTS. And what we always say is that ENT causes of vertigo are not really dangerous. So as long as the important and dangerous medical causes have been ruled out, we're very happy to review them. That's it. Thank you. Anyone have any questions? Okay, no questions?
Anyone from the medical team?
No. Okay, well, thank you guys.